the good, the bad, and the ugly.
Thank you, Dr. Adil, for the introduction. Hi, everyone, and thank you, Lexicon, very much for inviting me. Glad to be here speaking to you and your audience. You know, whenever I interact with medical students and graduates from India, it always reminds me of my wonderful days in MBBS when I was at JIPMER Pondicherry. So it's wonderful to be connecting with you all. And so I'm Dr. Agrawal. I'm a practicing nephrologist for the last about 12 years and also a faculty member in a teaching hospital. Really love to interact with medical students, residents, and fellows. Now, I started Ed4Med US about 4 years ago. This is a service that I started for international medical graduate, IMGs, and to really help them, you know, improve chances of getting into US residency. I'm sure many of you would have heard about the 2023 match. It just happened, you know, last week, and very excited to have worked with many hardworking IMGs and that I could help them match into residency. My focus mainly is on, not really on usmle tests because there are so many excellent resources, but there are other parts of the application like the personal statement and the practice interview, which really can make or break one's chance of getting into residency. And you can look at my website for the many courses, all the posts, reels, and YouTube videos I have out there. Coming to today's topic, US residency, the good, bad, and the ugly, just like the movie title, I chose this topic because I really feel US residency is of great interest to MBBS students and graduates from India.
Yes.
You know, I looked at the statistics. There are about 35,000 US residency positions, and about 7,500 are those positions are taken by international medical graduates. And guess where most of the IMGs come from? They come from India. About 25% of the IMGs come from India. That just tells us about the huge interest and the high level of interest that's there among, you know, MBBS students and graduates to take this journey to US residency. The goal is to give an overview of US residency so that when your audience, you know, the MBBS students and graduates who are thinking of doing rotations, electives as students, or they're going to be doing these observership externships as graduates, they're not going to be in for a surprise once they have, you know, some of the information that I'm going to share with them in this talk. So let's start with the good aspect. What are the good things about US residency? Now, certainly when I first, you know, got into residency, even a few days before residency, I really didn't know what to expect. All I knew it was going to be busy. All I knew that, you know, work hard and play hard. But just a few days into residency, it became very clear to me why US residency works so well. And the reason is because it's very balanced. What do I mean by balanced? Balanced in terms of the clinical work that you have to do, and then having time for learning, your own education, time for research, and so forth. And because the work hours are very tightly regulated by ACGME, the Accreditation Council for Graduate Medical Education, think of this as the NMC in India, the National Medical Commission. And on you have your daily rounds, you have your daily progress notes. They are very structured. There's a very interesting template called the SOAP format, SOAP, Subjective, Objective Assessment and Plan. I feel this is a very, very nice approach because it really forces you as the resident to address every concern, every patient problem, lab abnormality, and so forth, and what you're doing about it. It really forces you to come up with a plan. And as you go on to your second and third year and so forth, you just get faster at it. So for example, if someone has a COPD exacerbation and is a diabetic, you know, your plan would be something like, okay, I'm going to start them on glucocorticoids, antibiotics, bronchodilators, home oxygen. But at the same time, What are you doing about their insulin regimen because they might get hyperglycemic? So what are you doing about their hypertension control, their deep vein thrombosis prevention? So it really forces you, and then it becomes very, much internalized by the time you finish residency. You also get options to choose your electives. For example, I had an interest in nephrology, so I was able to choose a 2 to 4 week of elective, even in my first year and second year. And so they really encourage you to, pursue your interests. Evidence-based medicine, that's huge. The whole practice in US residency and even beyond is evidence-based medicine. Every computer in the hospital has UpToDate, which many of you may know is really a wonderful resource to find out, okay, what antibiotic should I give? What dose should I give? Or, what should I do in this situation? What's the evidence for this therapy versus not the next one? So it's really very much encouraged and practiced every day. So you really, by the end of residency, become very much aware of how to take care of patients as per the standard of care, as per the current evidence. The programs really encourage you to go for conferences, and so that works out well. You have CME money to funds to help you go for that. The fellowship options are amazing. Once you go into residency, many more doors open for you if you want to specialize in a certain specialties, even specialize even further beyond that. Lastly, a lot of advances are happening in education, in residency education. Point of care ultrasound is really picking up here in US. Palliative care is another one where you talk about end-of-life discussions, patients with terminal illness. That works very well. So because of some of these reasons that I mentioned, the well-structured, the well-balanced curriculum, what's interesting is you don't need to be in a top-ranked hospital to be a very good internist or a psychiatrist or pathologist. So because, again, ACGME regulates, okay, how many ICU months are needed for residency, how many procedures you need to do, how many line placements, what's your research requirement. So that's uniform. And so, so for example, you don't have to be at a top-ranked institute like Harvard or the Ivy League institutes to really be an internist. You can go to any hospital. From my own perspective, I trained in a community hospital, not really a university hospital, but that still worked out great because in the end, the ACGME regulations make sure that that the minimum standards are adhered to, and that works very well. The people, by people, I mean it's the patients as well as the physicians. Working with the people, I'm sure we all realize nowadays that to be successful at work, it's not really, the website or how fancy the building is. It's mainly the people that determine how you're going to like the work.
That's correct.
And the patients I've worked with, they're very appreciative. They listen to you. They follow your instructions. Many of them respect you. If you respect them, they'll respect you. It's as simple as that. I've never had or heard about any situations, any assault situations, any attacks based on how I look or how, where I'm from. That's never really happened with me. Work culture is very, very professional. You are really, you will be responsible for all your actions, held accountable. There's a wonderful word called autonomy. As you move forward in your residency, you will be expected to have more autonomy over the decisions about your patients. And that, sometimes it can be scary to kind of have that much autonomy, but that's what US residency really allows you to grow, have that professional growth throughout your years of residency. There's another word called leadership. So when you have this autonomy, you build leadership skills. And that's a wonderful thing to have. Even if you have leadership before residency, which is something I like to tell my residency applicants, it really, allows you to work very effectively during US residency. The bad aspects, let's talk about that. I really want to give a very balanced view of US residency training. US residency can sometimes be inefficient. There's a lot of documentation burden in your day-to-day work. Interestingly, there was a paper, like an Annals of Internal Medicine 2016 paper, where they really showed that for every 1 hour of patient face-to-face interaction, 2 hours are spent in documenting, ordering stuff, following up, and so forth. So there's a lot of EMR, electronic medical record burden, and so much is written about inefficiency. You must have seen some of Dr. Glaucom-Flecken's YouTube shorts where he talks about internal medicine residents admitting an orthopedic patient with hip fracture. So some of those things do happen. I guess it's all a part of learning, and just do your best. No system is perfect, but sometimes it can feel a little bit on the inefficient side. And another bad thing sometimes, I feel or I see residents talk about is sometimes they feel, they question, how effective is my care for my patients. That is, so, when I saw my first patient who in the ICU with sepsis, with pneumonia, who was on tracheostomy ventilator, had a PEG feeding tube, sometimes, it made me wonder, are we really helping the patient or just prolonging their suffering? Other instances come in mind. You're talking about a patient with lung cancer whom you're talking about chemotherapy, but at the same time, the patient is smoking. So sometimes you wonder, you really want to give the benefits of modern medicine to your patients, but, sometimes it gets a little bit tricky. And personally, I really look up to those physicians, including mentors of mine, who had the guts to tell the patient and their family, you know what, it's just not working. We're going to have to stop and we're going to have to let go. And that's what palliative care is all about. Sometimes you also worry, you come across these situations about costs of medicine. Now, this doesn't really apply a lot in US residency because you're working in the hospital, in the clinic, so you don't experience much of that. Like the other day, there was this question about this medicine called tolvaptan. That's a medicine for hyponatremia, those aquaporin inhibitors. Or there's something called rituximab for vasculitis. So sometimes it gets difficult to have those provided to the patients, not really in the hospital, but outside the hospital. I don't think you have to worry too much about that during residency, but it's something that needs to be taken into account when you're practicing.
Okay.
Let's go to the last part, which is the ugly aspects of US residency, which can get interesting. And the first, I would say, is the whole residency application process itself.
Yes,
it's very complex, starting with the USMLE exams, then, getting your rotations or clinical experiences, applying, interviewing, then making this match order list, going through a process called scramble or SOAP. And it can be very daunting, very frustrating at times. In fact, someone just posted on Twitter a few days ago about the cost, and they said it was about $11,000 for the applications, about like 9 lakh rupees for just the application process, the exams, the registration, the programs you apply to, and so forth. It doesn't include the cost. It doesn't include the cost of when you're physically here in the US to do your 3 to 6 months of clinical rotations, your US clinical experiences, because you need letters of support. So, and then, you see some of these applicants I've worked with who unfortunately did not match. And then there's not much transparency. So you don't really know what didn't work out, what should they do next. You can make an educated guess as best as I can, which is something that I help my residency applicants with. The last part I would say that's ugly about US residency would be something called burnout. And there's a huge amount of burnout among residents. Maybe even about 50 to 60% have, in surveys done, talked about burnout. It's not clear if it's like a US residency thing or it's internationally done, it's an international problem. But, whether it's the whole practice of medicine, how patients are demanding of us, or our own, role in this burnout, it's still not very clear. Only one thing I can say that really works out is having a good network, a good social support. That's what it's called, having your friends, your family, your mentors, attendings, whom you can freely talk to and discuss. That's really the one big thing that goes against burnout. So with this information, I talked about the good, the bad, and the ugly of US residency. I really hope this just gives you a very quick view of what to expect when you do your rotations or even your residency. If I have to end this talk with one piece of advice, I would typically say work on your communication skills, work on your writing, your speaking, even talking with people, from other countries. How you talk with them, how you exude confidence, that really plays a huge role in success. And that advice just doesn't applies to US residency, but also applies to if you're practicing in other countries. The US work culture is very extrovert, so you have to force yourself to be bold. This is one very good advice I give to all my applicants, residency applicants I work with during an interview. So at the end of the interview, they'll say, I think I'll be a good asset to your program. And I tell them, you have to be much bolder than that. You have to force yourself, you have to practice and say, I really believe I'll be a very good fit for your program. So I really, help them practice. And then I really feel that confidence does make a difference in how you appear to the other person. I'll get a request from a medical student. Do you have any research projects that you're doing? So I'm not going to reply to that. But if someone says, I understand you have an interest in kidney stones in bariatric surgery, can we write a review paper together? Can we write do a systematic review? Then you're being very personalized and very, bold about approaching me, and then you're very likely to get a reply from me. So this is what I was talking about, really improving your communication skills. And again, just doesn't apply to US residency, it applies to every aspect of your life as a doctor. The harder you work, the communicate and network with others, the more your chances of professional success. So I hope, just wanted to show that there's a learning curve in US residency. Many of you have done it successfully before, and many of you will. So with that, I'm happy to take any questions that your audience may have, and certainly feel free to DM me or WhatsApp me, and happy to answer any questions.